Welcome, everyone. Sorry for the delay. My name is Chris Hall. I'm the program manager for the Center for Excellence in Collaborative Education. We're thrilled to have you all here for this conversation about medication-assisted treatment. It does indeed take a village, and I think that we have some incredibly knowledgeable facilitators and presenters here today. And if you got here a little bit early, you were able to hear some conversation about how the rules are changing moment by moment. So thanks for attending, and I hope that you'll find this useful as you move forward in your education and practice. And I'd love to introduce now Jennifer Van Duzen, who is going to be our host for today. Jen?
Hello, everyone. Thank you so much for taking time out of your busy day to join us on this important topic. I'm Jennifer Van Duzen. I'm clinical faculty at the College of Osteopathic Medicine, and I'm going to take a moment here to ask our experts, our other presenters, to introduce themselves so that you know who will be working with you today.
Good afternoon, everyone. I'm Stephanie Nichols. I'm an associate professor in the School of Pharmacy, and I'm also really excited to see you all. And I see a lot of you pharmacy folks, so thanks for joining.
Good afternoon. I'm Kelly Harmon. I'm a faculty member at Maine Dartmouth Family Medicine Residency Program, which is one of UNE's College of Osteopathic Medicine's clinical campuses. And I'm happy to join as well.
Meredith Norris, DO, here in the capacity of somebody who's been working with medication-assisted recovery for about 15 years. I am medical director of an intensive outpatient program that has campuses in Sanford and Augusta, medical director of the methadone clinic in Westbrook. I'm currently at an opioid health home in Biddeford, and I have a private practice in Kennebunk where I treat opioid dependence, other kinds of recovery issues, and primary care and stuff. Glad to be here.
Hi, everyone. I'm Deb Kramlich, Associate Professor and Assistant Director for the ABSN program in the UNE School of Nursing and Population Health. And I'm really excited to see several of our students joining us in this conversation.
Hi, everyone. I'm Amy Littorini, part of the faculty in the Doctor of Physical Therapy program, as well as a program manager at Maine Health. Welcome, everyone.
Hello, everyone. I'm Jan Froelich, faculty in the Department of Occupational Therapy. Great to see you all.
I'm Kelly Fox, and I'm a faculty member with the School of Social Work. And one of my specialties in practice is addiction.
Hello, everyone. I'm Rebecca Guay, and I am a second-year pharmacy student at UNE.
Thank you all. I'm so grateful for your collaboration on this. And this is going to be a quick intro that what we're going to do today is introduce you, give you some background with a brief set of didactics where some of our presenters will share some expertise with you, so give you a baseline. And this is what we hope that you will learn and be what you'll be able to do and have attitudes about after the session. So we'll have some brief didactics to set the stage, and then we will put you into breakout rooms interprofessionally so that you will be discussing a case and your profession's role in this treatment of our friend Joe that you will meet. Then we'll reconvene from the Zoom rooms and hear what you talked about and answer any questions or thoughts that you have. So that will be how the session will go. So without any further ado, I'm going to ask Dr. Nichols to kick us off.
Thank you so much. I'm very excited to set the stage here and talk a little bit about epidemiology of the opioid crisis, both in the country and then specifically in Maine here. So you can see on the left-hand side that many people are diagnosed with opioid use disorder. In Maine, about 14,000 people. In the broader New England area, over 100,000 people. And then across the country, we're looking at very high numbers, over 1 million people, nearly 2 million people. And you can see this impacts people, in general, people that are teenagers or adolescents or adults. So 1.2% of our people, our patients are people that are 12 years or older in Maine do have a diagnosis of opioid use disorder. And certainly our numbers are higher than you can see in our geographical location of New England and compared to our national statistic of 0.6%. On the top right, you can see here the amount of people age 12 or older, the amount of people age 12 or older that are diagnosed with opioid use disorder. And you can see the different age groups that are impacted specifically over the years. And overall, while some age groups are going down, you can see that other age groups are remaining stable, particularly those that are around 26 years of age or older. And you can see on the bottom here that across the country, our diagnoses of opioid use disorder are somewhat declining from 1.2% in New England and 0.8% across the country down to 0.9% in New England and 0.7% across the country. What we're seeing in Maine is a different trend. So in 2015 to 2017, about 1% of our population did have this diagnosis. And unfortunately for us, that's going up to that 1.2% in 2017 to 2019. Next slide, please. And so again, you can see here in New England and in Maine, we're disproportionately impacted by the opioid epidemic. This is opioid poisoning mortality rates per 100,000 people. And this is from the year 2019. And I'll show you in just a minute that the 2020 numbers are a little bit different than this, and we'll talk about this. But in 2019, Appalachia, and I think you can see my mouse here, Appalachia as well as New England were the most impacted by opioid poisoning deaths across the country. The highest opioid deaths occurred in West Virginia, and it was 52.8 per 100,000 people. Massachusetts was number 9, New Hampshire number 10, which really represents a decrease from their highest, which I believe was number 2 or number 3. And then in Maine in 2019, we were actually 14th. With regard to opioid poisoning deaths. The lowest you can see in Nebraska. Next slide, please. And so you can see here opioid poisoning mortality in the US in blue and in Maine in orange. And you can see that in 2018, we actually had a reduction. So our rates were going up, particularly in Maine for many, many years, about a decade. And then in 2018, we actually had a reduction. And at that time, we were the 12th highest in opioid opioid poisoning mortalities. Unfortunately, I'll show you some data in a second that trend has reversed a little bit here. Next slide, please. And so this is the Maine mortality trends, and you can see from 2015 through the third quarter of 2020 that the mortality trends, mortality numbers do jump up and down a little bit quarter to quarter, but you can see overall there's a trend up. Through 2020. We did see that blip down in 2018. I think that represents all of the great work that we're doing and we continue to do in this state. But unfortunately, we had a pandemic and we're definitely seeing the impacts of that with regard to opioid use disorder and opioid poisoning deaths. Next slide, please. And so this is the data from 2020, and this is really scary, I think. You can see the opioid poisoning death rate per month here. So you can see overall about 42 Mainers, people who live in Maine, were losing to opioid poisoning every single month. And I just got news this morning that we have a concrete number for 2020, and that's that we lost 502 people. 502 people in Maine in 2020. That's nearly 10 people per week. Sorry, I'm out of time here, but I'm almost done. Nearly 10 people per week. And unfortunately, I also just learned this morning that makes us number 8 in overdose mortality nationally. So we were doing better in 2018. The trend's getting worse again. We have a lot of work to do still. Next slide, please. And this just gives you a little bit of geographical trends. So our most disproportionately impacted areas here in Maine include Androscoggin County, Penobscot County, and Washington County. And that is what I have to share with you. Next speaker, please.
Thank you, Stephanie. So I'm wanting to speak a little bit about opioid use disorder as a chronic disease. And the definition of a chronic disease is one that persists for a long time, definitely lasts more than 3 months. And typical chronic diseases that we're working with patients on are things like hypertension, diabetes, and primary care practices are very skilled at doing this. These are diseases that cannot be prevented by vaccines. They are not cured necessarily. You just try to reduce the impact on the end organ damage and extend life as best as you can. Over the age of 65, many Americans have a chronic disease. And one of the features that's really important to keep in mind is that behaviors that are damaging to one's health are big contributors. So opiate use disorder really needs to be thought about in that context. Next slide in the video. So this is just a quick video describing opioid use disorder as a chronic brain disease.
This may be your brain on drugs, but what actually happens in the mind of someone addicted to drugs? It all starts with the brain, specifically something called the reward center. One of the brain's goals is to keep our physical bodies alive and reproducing. So when we do something good for our survival, like eating delicious food or having sex, our brains produce chemicals that make us feel good. These chemicals are called neurotransmitters, and they're basically the way our brain and body communicate with each other. The brain produces hundreds of neurotransmitters, but when it comes to addiction, the most important one is called dopamine. Dopamine makes us feel good, so we want to do that thing again and again. Basically, our brain is training us like we'd train a new puppy, but learning doesn't always go the way it's supposed to. Substances like heroin or other addictive drugs are the jackpot of the dopamine world. Not only do they produce more dopamine than other activities, they make your brain think that the reward is even better than you remembered. So just like that puppy who wants to sit and get a tasty treat, you want to do more drugs to get that good feeling. Over time, drug use can also change other parts of the brain. Some connections, like the ones related to impulsive behavior and emotional responses, get stronger, and others, like those used in decision-making, get weaker. Those changes can also cause physical dependencies. If you've ever gotten a headache from giving up your morning coffee, you've had a minor experience of what it's like to go through withdrawal. Withdrawing from more serious drugs like alcohol or heroin can cause breathing problems, irregular heart rate, and seizures. Of course, everyone reacts to different drugs in different ways. Lots of people binge drink in college, but most of them won't become alcoholics, and scientists are still trying to figure out why. For all the research that's been done, much of the brain remains a mystery.
So next slide. So the difference between opiate use disorder and in other chronic diseases is that we don't have as much time, as much lead time to help patients prevent end organ damage, and death is fairly imminent in some cases. So by the time from diagnosis to the time that it can really have a major impact and potentially fatal consequence is shortened. And so this is flipping the model of managing this as a chronic disease, so that we have to do a lot of upfront work before somebody can have some improvement in the disease process. So treatment is very accelerated. And I am happy to answer questions, down the road, but I'll turn it over to the next presenter.
Good morning, everybody. This is going to be kind of like a Pechacucha, except not 20 slides, so we're going to be just rocketing through them. I wanted to address some of the kind of common myths about opioid prescribing, because we tend to attribute the way the disorder works to different stimuli than is actually the case. And similarly, we tend to make solutions that are not going to consequently be appropriate. So one of the big ones is that I can give you a substance use disorder with my prescribing. We've all heard the narrative that, 2010 was going to be the decade of pain management, and then we all got everybody addicted. And the reality is, of people exposed to an opioid, fewer than 7 to 10% get an SUD. And so if you think about the number needed to treat for all you epidemiology buffs out there, we're taking 90 people off appropriate opioids to prevent that 5 to 10%. Of people who have a substance use disorder, maybe 30 had their first exposure through a prescription, but that means that's just what became their drug of misuse. It doesn't mean that this is kind of what happened. I will say better risk management could have prevented diversion. I trained in West Virginia, and then I moved up here, and so I'm very familiar with kind of, they called OxyContin hillbilly heroin when I was in West Virginia. Better risk management is certainly an element, but that was because there was diversion that was facilitating misuse, not that everyone who got a prescription got a drug problem. That's not how it works. Next slide, please. So the CDC guidelines were released in 2016 and kind of implemented in 2017. Everybody treated them as though this was canonic, and it was from on high, and it was based on really good evidence. I won't get into what exactly the recommendations were, but it resulted in great misapplication. Many states, including ours, started implementing laws around prescribing. Truth be told, except for one recommendation, which is that people with substance use disorder ought to get treated with evidence-based medicine, the levels of evidence was about level 3 or level 4, which is not something on which you should be making a lot of lengthy legislation that's going to impact a lot of people's lives. Pain and addiction medicine specialists were not involved in the creation of these recommendations. And the numbers, basically it said there's increased death associated with anybody who's on an MME over 100, and so just no one should be on that anymore, which is not how it was supposed to be implemented. It was not how it was supposed to be used. It was really just saying, let's try to keep it below 100 if we're starting new patients. There was no accounting for people who had been habituated for long periods of time. And the numbers that came up with those deaths of over 100 MME typically were not opioid naive, but were either opioid naive patients, or they were people who also had polypharmacy. So yeah, they were ingesting more than 100 MME, but it wasn't as clear as, and that's what killed them. There were usually a variety of moving targets. To further exemplify this, Dr. Nichols' slide about how the overdose rate went up in 2018, 2017. Guess what? That was right after the law went out that was supposedly going to fix the problem. And what it did was restrict prescribing capacity of opioids, resulting in a greater market for fentanyl and heroin, which is a much riskier form of substance use. It's more dangerous. Next slide, please. And yeah, this isn't what happens. When the laws / policy came out in 2017, people who didn't work with this were pumping their fists in the air because everyone loves an algorithm that, yes, if all those doctors stop prescribing, then this will fix our drug problem. And those of us who work in this were doing an action hero-like run toward the explosion going, no! Prohibition has never resulted in less use, just more risky use. The same thing happened with alcohol. Wealthy people still got alcohol. Poor people started using more dangerous forms of alcohol and having poisonings from them. That's how opioid poisoning rate went up, as I said. Used to be pharmaceuticals, now it's heroin. So thanks, it was a well-intended policy, but it had the opposite effect of what we wanted. Next slide, please. Can you all hear me? I'm getting a weird sign about my default microphone. I lack the technology gene. So the other thing is that now I'm getting a shakedown anytime I want to put someone on an opioid from people who aren't really going to be assuming the risk. It's me. Well, have you tried ibuprofen? Like, first of all, of course I have, but NSAIDs are not benign. Gabapentin is not benign. I'm sure Dr. Nichols will back me up on this, and that this is not tap water. And so trying to fix a problem that you can handle with a little bit of opioid by giving people a fistful of NSAIDs, these are the hospitalizations. So there's a lot of hospitalization and death. As my husband recently told a pharmacist who was giving him a hard time, well, we don't say we have an NSAID crisis, do we? But we're having a lot of deaths from that. And no, most pharmacists aren't that way, just this particular one. Morbidity and mortality, gabapentin, pregabalin, seriously underreported because we don't even test for it mostly. And undermanaged pain is a risk factor for suicide. It's not benign to take people off their opioids, especially, as I already said, 90% of those people were using them appropriately. Next slide, please. Also, I have people who are under the impression that if somebody has a substance use disorder, they shouldn't get pain management. If you're a human being and you have bad pain, you haven't lost your right to effective analgesia because you have a history of a drug problem. Additionally, yeah, you're going to have to really hammer people. So if this person comes into your emergency department or into your whatever, don't withhold appropriate pain management in a controlled setting because you see in their PMP that they're on buprenorphine or that they whatever. They're actually going to need to be hammered pretty hard with pain meds because they probably have prior habituation. Also, if somebody comes in and they have methadone on their prescription, they're being given it for pain. Don't send someone to a methadone clinic to treat their pain because methadone for a clinic is dosed once a day, which is good coverage for mu receptor agonism for recovery, but it's not good for pain management. So if somebody's at my office and they have a prescription for methadone, I'm choosing it specifically because it's a long half-life and is not euphorogenic. I'm not treating a substance use disorder. And if you go to a methadone clinic, you're getting dosed in the morning, you may still need pain management. And I see a lot of people because they get hot potatoed off to me. They go to a methadone clinic and no one wants to touch them for their pain, but they have a pain syndrome as well. And there's ways to do that. I think I might be done. What's my next slide? Do I have one? All right. And that's all. But yes, by all means, hit me up if you have further questions. And do remember, you're the most important patient you care for. So be kind to yourself. You're all doing something really hard under really weird circumstances. So make sure to check your own pulse first. Thanks, everyone.
So medication-assisted treatment is actually transitioning to be termed medication-assisted recovery, but you will still see medication-assisted treatment or MAT in your various practices because it takes a little while for this terminology to catch on. But basically, it just means that we're using a medication in addition to counseling, and behavioral therapies are something that needs to be part of the treatment, and it's actually the most important part of the treatment. The medications certainly help to take away the physical symptoms that patients have and improves withdrawal symptoms. But the real work is the behavioral health piece in medication-assisted recovery. So referring to counseling, encouraging peer support. So we used to really rely on 12-step meetings, but there are many, many ways to get peer support, and that's also a big part of medication-assisted recovery. And then LOCA that stands for a level of care assessment, and that is very helpful to determine just how intensive care somebody might need. Next slide. So this is just a resource. Provider Clinical Support System has waiver training for medical students, and it's hot off the press. The Health and Human Services Department has just made an announcement that they will no longer require waiver training for prescribers. But I will also add that you can expect that going through this training is still going to be required as part of professional education. And certainly there are many, many people that are practicing that did not have this training in medical school or in their professional education. And waiver training is still going to be a mainstay and quite valuable, even though it may not be a requirement in the future. Next slide. So there's different options for medications for opioid use disorder, and the FDA approved options are methadone, as Dr. Norris just mentioned, buprenorphine, which is I think the most commonly seen here in the state, and that comes in tablets or films that are dissolved under the tongue. And then naltrexone is another option and a little less used. Next slide. And medications, again, are very helpful. They're going to reduce cravings. They're going to reduce symptoms like dreams of using substances. And they'll certainly reduce physical withdrawal symptoms, which are very uncomfortable for patients. So when patients are in opioid withdrawal, they'll describe it as the worst flu ever. And so this is where medications can be very, very helpful because it can help keep them from being distracted by those physical symptoms and kind of propagating the cravings. So when you can kind of alleviate that, people just feel more like themselves and are able to focus on the things that help them maintain usual activities of life. So again, these just help patients focus on the behavioral changes that they need for their brains to heal, for their bodies to heal, and for them to participate in society and do all the things that they would normally be able to do prior to having a life affected by substances. Next slide.
So that was a wonderful lead in, and our title today, referring to the village, it does take many villagers, and this is sort of a summary of not an exhaustive list, but certainly some of the interprofessional villagers that are in partnership with our medicine and pharmacy colleagues, assisting patients in early and long-term recovery. And so from a standpoint of some of the professions represented here, nursing, certainly OT, PT, social work, and our integrative medicine colleagues are important here. And so from a phasing perspective, when we think about the patients in acute and early recovery, some of those immediate symptoms that Dr. Harmon was discussing, that immediate traditional response to the things that are in our wheelhouse, rehabilitation, nursing care, counseling, all of the things that we are able to assist the majority of our patients with, just sort of embrace your ability to use some of those skills. So pain management, certainly safety, gait training. I'll just also remind medication-assisted treatment also extends to individuals with alcohol use disorder. So the incidence of neuropathy is certainly there. And so issues with balance can be present. Basic bed mobility and transfers, ADLs, certainly. Counseling, when we think about the percentage of individuals who have co-occurring conditions with substance use disorder, certainly those diagnoses need to be addressed. But it's really the behavioral health and the peer support piece that goes into that is really critical. And when we think about the recovery sort of tenets and the pillars of recovery, access to community resources for these four things, and remember these when you're talking about Joe's case: health, home, purpose, and community. If one of those four is missing or lacking or deficient, we really need to do everything we can to try to promote access to improve that aspect of that individual's life. And then in long-term recovery, it really is the development of strategies for them to become independent in managing their condition, being a chronic condition. So things like self-care techniques, a lot of the integrative medicine strategies that you see listed there, certainly pain management. And as was beautifully articulated earlier, there are many of your patients who are still going to need medication for their pain, but what other tools can we put in their toolbox? So using things like TENS, trigger point releases, acupuncture, acupressure, massage, Reiki, certainly that their ability to access them becomes important. Physical activity has been shown in some systematic reviews to assist with abstinence for various use disorders, and accessing the outdoors. We're very fortunate here in New England to be able to do things like forest bathing, and really accessing fresh air and sunshine is very therapeutic in recovery. And really establishing those meaningful habits, going back to health, home, purpose, and community. If we can assist them with that, and that social support certainly is important. So as students becoming clinicians, we need to really embrace our opportunity, learn as much as you can about SBIRT, learn as much as you can about harm reduction, trauma-informed care, and really, regardless of the setting that you're in, you will encounter these individuals with these disorders. So just think of each patient and meet them where they are, and understand your wonderful opportunity to be supportive to them. Next slide.
Thank you so much, everybody. That really set the stage, I think, for what we're about to ask the students to participate in, which is meeting Joe. And there's Joe. We will put in the chat, Michelle already has put into the chat the case that we're going to be working for the next 20 or so minutes, 15 or so minutes. And in that also is a worksheet. And so what we're going to ask you to do is to make a copy of that, to label it with your group number, which you should be able to see, and skim through the case really quickly. And towards, as you see at the end of the case, there'll be a place for each of you, from your professional stance, to start thinking about how can you help Joe? What are the problems that you see and the support that you can offer? And what is your role as a member of the team that's going to help Joe move towards recovery? Be prepared, if you can have a recorder, someone who's prepared to report out at the end. We're going to be asking by profession to name one thing that your profession can do, and we will zip through those. Also, these presenters will be appearing in your Zoom room and will consult with you on your thoughts. So without any further ado, we will see you in your rooms, and we'll reconvene about 8 minutes before we end this session. See you then.
We hope to have some large group Q&A, and we'd love to hear in the chat from you about how your group's conversation went and what your major takeaways were.
It would be great if we could have, say, one group. Let me just check in with quick groups. Looks like we have a couple of minutes. I want to, the group that I was in really veered from a little bit. It got quite blurry. We didn't get to the roles and responsibilities. And much of what we discussed in group one really was more related to social work than medicine. So I'm going to ask Peter from group one if he would talk a little bit about what some of the top priorities were for Joe. And then perhaps we can have Dr. Fox comment on that. So Peter, can you share with us? Not sure we've got him here.
He needs somebody to unmute him.
Okay.
Peter, you have the power. Go for it.
Peter, could you weigh in for your group there?
Okay, there I am. So did you mean in terms of medication?
What I was asking, there seemed to be towards the end of our discussion really more focus on really what this patient needed immediately in terms of some of the issues that were coming up. So if you could just speak a little bit about that, maybe Dr. Fox could weigh in there for a few moments about the role of social work. She didn't get much chance to talk.
Sure. So one of the ideas brought up by one of our pharmacology students was that it would be a good idea to get this patient some naloxone to have, because it's important if he continues using, then he has this opportunity to potentially have his own life saved or save the life of a friend that he's with. So in a very immediate sense, that's one of the things that we were thinking about.
I believe you also were discussing his need for a place to live, and Zach brought up some of what kinds of recovery programs, what kinds of counseling had he already had. So Dr. Fox, can you make a few comments related to that particular need of this patient, please?
So I think, the things that you've already talked about are really the things that are really on top. I think one of the things that I missed in my group that Professor Froelich and Dr. Norris talked about was the housing first. That, the first thing to do is to make sure that this person can find some stable housing, because it's really hard to do recovery. It's hard to do medication assisted treatment. It's hard to do anything else until somebody has a stable housing for themselves. So I think, and when we look at ASAM criteria, that recovery environment, while we don't always take that into consideration at the top of the list, we also really know that it's hard for anybody to recover in an environment that's not safe. So I certainly think that the things that you've already talked about have been, are certainly on top. I think, one of the things for other folks who don't work in this realm is to really become familiar and get to know the programs and the resources in your community, or get in touch with a social worker that or a social work organization that that can help with getting some of these other needs met while the medical needs are being met as well. So.
Terrific. Thank you. Thank you very much. Social work has a huge role in this particular form of treating this chronic disease. Thank you so much. So just last but not least, let's just hear from the pharmacy students. So I'm just going to ask any one of you of the pharmacy students who'd like to talk a little bit about what came up for them. And then we can hear a little from Dr. Nichols. And I think then we will be ready for our, ready for some questions, hopefully. So just really quick, brave pharmacy student, want to weigh in, jump up and speak?
I think Hillary might have something to say if I'm reading her face correctly, but she can't unmute.
Oh, Lee, can you unmute Hillary, please?
Everyone has the power to unmute. There's nothing, it's all, I can't go through the computer, unfortunately.
Okay, I tried to hit unmute and it said the host will not authorize you to unmute. So I don't know why it's working now, but here we are.
That was before Q&A.
Gotcha. Well, anyways, here we are. So we talked about, as Peter brought up, we talked about making sure this person has access to Narcan, since clearly overdose risk is an issue for him and possibly the people around them. And my group also talked about, although pharmacy didn't come up with this, but access to clean needles, if that's something that needed, and that's something that we can do on a community pharmacy level. And I certainly think, especially because this person has reduced, they have vocalized an interest in quitting, that, talking to them about talking to what's available in terms of, Suboxone or other tools or medications to help them quit. And we can talk about we can talk to them about the pros and cons, and, but also just making sure, I think all healthcare providers are responsible for making sure that patients are aware of what resources are available to them.
Really well.
Their community.
Thank you. I'm going to cut you off and ask for more input later from Dr. Nichols. And let's go to Rebecca and see, Rebecca, what was the most pressing question that you came up with that, or that people expressed in the chat? Can we go to that?
Yeah, most of the questions had been answered directly in the chat. There was a question that was asked about forest bathing and just an interest in if that's just being in the forest, but that was never answered.
Okay. I'm going to go ahead and answer that as we close. Yeah, it was, unless you have, do you have a sentence, Dr. Littorini? Do you have a sentence you can real quick? Because we
Sure. I mean, there's data. We know that for people who live closer to green spaces, there are definitely improvements in their longevity. And we also know, just from a health perspective, from blood pressure, there's really great data on it. And we are so blessed in New England and in our state in particular with the ability to get people outside and to really access those spaces. And so yes, it is a thing. Look it up. It's really one of those things we should all be recommending.
Thank you so much. And everybody, I want to remind you about the sign-in, I'm sorry, what's it called? The attendance sheet. Please go to to that attendance and fill that out. We need your input. And there's the code for it. And I'd also want to make sure that you give us your feedback. We know this was a lot to do in an hour, and we appreciate your patience. Any way to continue these conversations, we will do so. And I want to thank the presenters for just being here and offering your expertise and being present as a champion as we fight this, this other epidemic that we are in the middle of. And thank you all, students, for your interest and your passion and for attending, and for CC and for your extraordinary work. So thank you all. We'll see you soon.
Thank you, everyone. Have a great afternoon.